estimating equations, and which is Andy and which is McGee in this cartoon. I'll leave it to you to work out. The other thing that I had to think about is that my brief was to look at this from an international perspective. And as we've heard a couple of times already in the conference, the theme of the conference is sustainability and diversity. So here is what I'm going to try and talk about to you today. A word about sustainability first. I then want to look at things from the international perspective, and then look at the way that we grade recommendations and a little bit about the evidence. And McGee is quite right to raise questions about the evidence. And then to look at research and CKD and the gaps, and to consider what's important. And again, to do that from an international perspective. We start off with sustainability. I already gave you the definition of sustainability, but what we know is that our current and future behaviours are having a major impact, and that's on global climate disruption. And the WHO identifies both direct and indirect effects of climate disruption, and these are important. Malnutrition, and you can start to think about intrauterine malnutrition, nephron number, storms and floods, water scarcity and contamination from flooding, increasing diarrheal illness, etc. Heat waves which have a direct effect on morbidity and mortality, and the change in the geographical distribution of vector-borne disease. And these direct effects, perhaps leading to indirect effects of economic collapse and mass migration. And they're very important international perspectives to think about. And this is a theme, the international theme is a theme that's been developing since the opening session of the conference, when we first heard about age-standardised disability-adjusted life years and how they varied globally. We heard about that again from Richard Horton in the previous session that's just gone. And of course, the best quality of life or healthy life estimates come from Japan, where their average healthy life expectancy is 76, and the worst come from Swaziland, where the average healthy life expectancy is only 30. And we also have a marked variation globally in the major risk factors for chronic kidney disease. So here's another one of the WHO health maps, just showing you the global variation in prevalence of hypertension in those over the age of 25. And of course, diabetes is hugely variable as well. And we hear a lot about diabetes. This slide is showing you the top 10 countries in terms of millions of people with diabetes. Only 2 of these countries in this slide are high-income countries. The rest are middle and low-income countries. We've heard a lot about middle and low-income countries already. And together, these countries constitute 75% of all diabetes. And of course, the bigger problem is in these much smaller countries, where the epidemic is rapidly increasing. This has a major economic impact on these countries. Now you may be starting to wonder what all this has got to do about the KDIGO CKD guideline, but KDIGO has a global perspective on this. KDIGO is tasked with giving you a public health approach to things as well. And having set out my stall, I'd just like to share with you the provenance of the guideline development members. There's a fair international flavour there. There's people from the States, from the UK, from China, from Japan, from Brazil, from the Netherlands, Spain. I think I've captured most of them. So this then is the guidelines and evidence loop cartoon. So we have research which generates evidence, and that evidence may be directly disseminated and accessed by clinicians who naturally start to ask questions of the research, generating more research and more evidence. Guideline development groups take that evidence and they look at it. They may decide that the evidence isn't sufficient to produce a recommendation, so that leads directly to research questions. Or they may bring the evidence together into guideline recommendations, and the implementation and subsequent evaluation of those recommendations again generates research questions. You've heard some of them already. McGee asked about the evidence. Well, here it is. These are the numbers of articles published in the last 30 years, peer-reviewed articles available in the literature on human chronic kidney disease. You can see there's been a literature explosion, and since the KDOQI guidance 10 years ago, there have been over 50,000 articles on human kidney disease. This red bit at the top is the bit which is the clinical trial, RCT, meta-analysis and systematic review data. And although this red bit is increasing, it's obvious that we still have a largely observational evidence base on which we make guideline statements and recommendations. So the way that we look at the evidence then is to consider the quality first, and we use the grade system. So we start off with the high quality studies where we're confident that the true effect lies close to the estimate effect of the effect, the moderate evidence where the true effect is likely to be close, but may possibly be substantially different, and then the low where the true effect may very well be substantially different from the estimate of the effect, and the very low which is pretty much fiction. And we then grade the quality, we put the quality into strength of recommendations. So a level 1 recommendation would be where all of your patients, pretty much everybody would want that. Most clinicians would want their patients to receive it. The policymakers are pleased with it as well because it's good for policy and it's good for developing performance metrics. You don't necessarily have to have high quality evidence to make a strong recommendation, and the obvious analogy is the parachute. So there is no good quality evidence that tells you to strap a parachute on when you leap out of an aircraft. But nevertheless, none of you would not be making a strong recommendation to do so. And then you have the level 2 strength where the majority would want this, but many wouldn't. And for clinicians, it's very much about horses for courses, so they might use this kind of recommendation to individualise things. And for policymakers, well, it's no good at all, it's very dodgy policy. And then the final category are those that are not graded, where a recommendation is used to provide guidance based on common sense or where the topic doesn't allow adequate application of the evidence. So there were a total of 110 recommendation statements in the guideline. And of those, 22 were low or very low quality, and only 11 were high quality. And when we look at the strength, there were a couple of parachute recommendations there. In other words, where the quality of the evidence was low, but the strength was high. There were 41 who were not great. So you can see my dilemma here, because there are a lot of gaps. If you're charitable and you just take the not graded and the low quality, low strength recommendations, that's 50% of the guideline you have to ask questions about. When you look at that in terms of the section of the guideline, then roughly 50% of section 1, all of section 2, 50% of section 3, a quarter of section 4, and about 60% of section 5. So now we have to return to the question of what's important, because we can't go through all of these questions. And here we have to return to the international perspective. And this was something that we tried to weave throughout the guideline, particularly in terms of clinical effectiveness versus cost and resources. So there's a certain minimum acceptable standard that we'd expect everyone to achieve. But what you then achieve above that depends very much on what your resources are and what the competing priorities are. And that's also important when you start to think about the research gaps. And of course it also depends on just how much you can afford. So if you're low income, then clearly you can't afford very much at middle income, high income perspective. And that has an effect on how you manage to afford the consequences of your public health problems. So this is showing you the international variation in incidence of provision of renal replacement therapy for end-stage renal disease in those countries that can actually afford to do it. As we know, the vast majority of countries that we've been talking about in the conference so far can't afford to do it. And that has a consequence in terms of death from kidney disease and death rate per 100,000. So here you can see the death rate per 100,000 of the countries who are represented in the guideline development group. There is some variation, but reasonably similar, but in stark contrast to that of El Salvador, which has the highest number of deaths from kidney disease per 100,000 throughout the world. So there are clearly differences here that we have to take into effect when we're thinking about what's important. So for me, it starts off with early identification and improved recognition of chronic kidney disease. And that has to be something we're going to do. And it's fairly logical, because if you can take people down the left-hand side of this slide, then you're not only going to improve things for individuals, you're also going to improve things for their health economies as well, and then globally. And there are many screening programs throughout the world, and we've heard quite a lot about this already. We heard from John Feely about ISN-supported initiatives in his opening address. And there are an increasing number of screening programs going on. Most of them look at diabetes, hypertension, and family history of chronic kidney disease as the risk factors in targeted risk populations. But of course there are other risk factors as well to consider. For example, insecticides in El Salvador, which leads to a lot of kidney disease in a lot of young people, and herbal remedies we've heard quite a lot about in China as well. And McGee's already alluded to GFR and albuminuria thresholds, which may be related to age. So in high-income countries, though, screening is not recommended. But when you take a closer look at the evidence, what you realise is that there are a huge number of gaps there. So there is no generally accepted risk assessment tool for chronic kidney disease or risk tool for complications of chronic kidney disease. No studies have evaluated the sensitivity and specificity of one-time testing with either or both GFR and proteinuria testing for diagnosis of chronic kidney disease, and no studies tell us how often we should repeat those tests. The role of cystatin C, you've heard a little bit about, but that's still to be fully evaluated. There are actually, despite the talk about harms of disease labelling, there are no studies that have looked at potential benefits and harms of screening and early treatment of chronic kidney disease in people without diabetes and hypertension. And although we have a few health economics assessments, I'm afraid, and I'm sorry about this, Cello, if you're in the audience, there are no really good health economics assessments that are going to inform what we're going to do about identification of chronic kidney disease globally. So we made recommendations about frequency of monitoring related to the heat map, which McGee's shown you already. The problem being, of course, this is opinion, there's no evidence behind this. Similarly, we talked about definitions of progression, how you might define progression. We're all very well aware now of the variability, and certainly the interperson variability in kidney function measures, and this was shown very elegantly in this study from the African American study of kidney disease, looking at the probability of non-linearity of progression. So we have a huge number of gaps in identifying progression now. We need to accurately define the frequency of GFR and albuminuria measurement to inform strategies which may prevent the adverse outcomes. We have to accurately determine the change in GFR and change in albuminuria that's associated with an increased risk of CKD progression. And we perhaps also should try and categorise progression into slow, moderate and rapid progression. We should say what we mean by that, and we should say whether or not that varies by the outcome that we're considering. We do, of course, have things that will prevent progression, and that's a good thing, because when we start to think of the huge societal burden that chronic kidney disease engenders throughout the world, particularly in terms of financial costs and loss of productivity that are associated with advanced chronic kidney disease, and if we think also that a number of countries throughout the world either have renal replacement therapy which is not available or not affordable. So simple things that we can do to try and prevent chronic kidney disease are going to improve things globally. But a lot of the simple things that we already do, we don't look at quite well enough. So in the studies that we have a huge amount of variation in the people that go into the studies, in the targets that are chosen, and whether or not Mandira pointed out in an article recently that we have studies that look at targets, and we have studies that just look at providing a single dose of a substance and then looking and seeing what happens. So we have a number of gaps here as well. When we think about treatment of chronic kidney disease and the proven evidence-based therapies, McGee alluded to the fact that in people with chronic kidney disease and no hypertension, we really only have evidence for benefit of intervention in people with proteinuria levels above an ACR of 70 milligrams per millimole or gram of protein a day equivalent. In those with hypertension, we have evidence going down to about an ACR of 30 milligrams per millimole. But what level of protein loss should we, and that's in hypertensives rather, so what level of protein loss should we be looking for in normotensives? People who don't have albuminuria, what level of blood pressure should we be treating people with reduced GFR to? And we need to ask the question about when RAS antagonism, ACE and ARBs, is harmful, and I'll come back to that in a moment. But the age difference is something that Nagid alluded to, and I'll talk just a little bit about that now. He also alluded to the fact that a lot of the so-called age-related decline in renal function is due to comorbidity. I think when we start to think about age, he's quite right to question whether we should have the same sort of factors that we treat to with every single age. And we perhaps should not be making blanket recommendations across, but it's quite difficult in a guideline not to have a blanket recommendation. I'm afraid guidelines are guidelines, they're not rules. But there is something here about first doing no harm. And if we just take the example of ACE inhibitors and ARBs, so we have evidence, as I've already said, for a number of different uses of ACEs and ARBs, and the other ones I didn't mention would be in resistant hypertension, in acute MI, and in heart failure. And if you look at people who have indications for ACEs and ARBs, then largely evidence of harm in those people who have the additional indications is not there. But if you look at populations in whom the only indication is simple hypertension who are prescribed these agents, you see quite a different picture. And there's emerging data about that, and we need a lot more because we need better information about who not to prescribe to. I think there's many of us in this room, so if I did Nagid's voting thing and asked you who in the room, when they're talking to a person in front of them with chronic kidney disease who has a reduced GFR, and especially if they're on diuretics, who will tell them that if they have an intercurrent illness, especially if they have an intercurrent illness which is diarrheal or vomiting, who will tell them to take a tablet of it? I certainly do. I would submit most of you in the audience do. Do you have any evidence for that action? No, of course you don't. And this is another area that we need to look at before we start thinking about blanket recommendations. Let's move on now to some very simple and cheap interventions that we have, but we don't have adequate evidence behind them. Let's start with sodium bicarbonate. 1827, Richard Wright proposed using bicarbonate to correct acidosis and slow progression of kidney disease. Let's fast forward 100 years now. We have two very small studies that suggest some benefit. This is a very simple and hugely inexpensive treatment, and yet we don't have good evidence to guide its use. And what about this one? This, of course, is vitamin D. We have a vast number of studies looking at vitamin D and bone disease in people with kidney disease, but we don't have anything which tells us whether vitamin D is actually adding any benefit to people with pre-dialysis chronic kidney disease. And we don't know which preparation to give to what level of kidney function, if it is going to add value. And then let's think about uric acid. There's a whole session about uric acid just following this one. But again, we have a number of animal models which tell us all sorts of things that uric acid may be doing that are deleterious to us in terms of hypertension, tubular interstitial fibrosis, glomerulosclerosis, vasculopathy, etc. And we have one or two small studies that suggest that maybe treating hyperuricemia may be a benefit. Allopurinol is now very cheap, but we don't have any study which really guides and tells us whether or not it's something that we could introduce around the world. I want to just finish with a few slides about this relationship. Now, those of you who were in the acute kidney injury session this morning will have heard about the complex interrelationship between acute kidney injury and chronic kidney disease, and I'm sure you're all aware of it. And in the latest session, we saw some estimates of acute kidney injury burden. I think Pepe Ramusi showed a slide about this. And these are estimates from high-income countries. So this is a billion population taken from the States, Australia, New Zealand, and Europe. And there are estimates of the impact of acute kidney injury. So 3 to 15% developing end-stage renal failure, 20 to 50% stage 4. And Andy Lewington's extended the model into middle and low-income countries. And this is a huge potential problem. It's a much bigger potential problem than you think about, because these models were done on an estimate of an acute kidney injury incidence of about 2,147 per million population per year. But we think the true incidence is actually a lot higher than that. And there's also acute kidney injury happening out in the community that none of us in hospitals see. So if you look in primary care databases and you apply acute kidney injury definitions, and you combine that with hospital databases, you come up with perhaps a much bigger potential figure. And this has a much bigger potential in the developing world. So this, again, is something we need to think very carefully about. And there are huge gaps in our knowledge here. So we need the prospectively designed clinical studies that have clear and uniform definition of CKD and AKI to tell us about the frequency of acute kidney injury events in the CKD population, the outcomes of acute kidney injury in patients with chronic kidney disease, especially acute kidney injury out with secondary care settings, and the importance of proteinuria, low levels of proteinuria to GFR in the risk of AKI. So, Chairman, there are 3 levels really that we should consider in determining our future research priorities. There's the individual person-focused benefit, and we should perhaps concentrate here on strategies for early identification, prevention and progression, reduction of cardiovascular disease burden, improved quality of life, increased productivity and reduced depression, so that we get increased healthy life expectancy and try and bring Swaziland up to Japan. It follows on then that if you can do this in the individual, there are benefits for the country health systems. And those benefits should be congruent with policy direction, ideally, and they should contribute to, not drain the economy. In other words, reduce financial costs and increase productivity. And then the benefits for global health care. We've heard already about the importance of including kidney disease in non-communicable diseases, because kidney disease has a major impact on other non-communicable diseases. And if we can do that, and if we can also factor in a little bit of sustainability, then maybe, just maybe, we'll be able to afford all of this. And I'll leave you with a mind map for research, and thank you for your attention.